a 16-week-old puppy, I think it is, that has an avulsion of the tibial crest after falling from a height. And so we're going to do a pin and tension band repair on it. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So I'm just making a little incision right down over the tibial crest, and I'm extending it far enough distally that I'll be able to accommodate my tension band. Can we get some Gelpia retractors, please? Choose, please. So the reason why we have to do a pin and tension band repair on this is because of the pull of the quadriceps muscle. If you just did pins, the quadriceps muscle is going to tend to try to distract that fracture. Whereas if you use a tension band as well, the tension band actually converts the distraction force of the quadriceps muscle into a compressive force across the fracture. So if you think about a telephone pole, and if you had the pull of the telephone wire in one direction, it would tend to pull the pole over. But when you add a guide wire to the telephone pole, it really stabilizes it because it neutralizes the tension force or the tensile force of that telephone wire and converts it into a compressive force down the pole. So it's the same idea. Can I please get some 054 and 062 pins? And maybe some 20 gauge cerclage wire. So we can see that we've got a lot of bruising here. That's the tibial crest sitting right there. So I'm going to dissect the cranial tibial muscle off the proximal tibia. And you can already see all of that bruising there. And so this is an somewhat over-diagnosed condition because people see the growth plate and assume that that is a fracture. So we can see already that that tibial epiphysis is being displaced proximally. So now I'm just palpating down the tibial crest here. Can I get the table up a little bit, please? Yep. Hi, Mexico. Hi, Brisbane. Just waiting for the table to be raised a bit. Yeah, that's great. Thanks.
I don't think so, Luke. I think that's touched the back of it, so.
You can cut it, the top.
What's that? What have we lost?
Oh, it's just,
I'm just palpating down that tibial crest there. Did we get a cerclage kit?
Yeah.
Cerclage kit will have pin cutters. I just don't know if they're big enough. So I'm just taking that periosteum off medially. Just get a little bit better exposure here. So let's see, 062s. I think 062s will be a little bit big for this, so we'll go down to our 054s, which will be perfect. All right, so just confirming that this is where our fracture is here, and that is displaced a little bit, but we'll compress that with our tension band. The thing I need to make sure of is how or where my landing zone for my pins are on the metaphysis of the tibia. Okay, so now we can see a little bit better even that that has really been displaced. Approximately there. All right, so we've got that big space there. So that's pretty nice exposure. I haven't looked up at the screen. Can you guys just, let me just make sure that, yeah, we've got a good view there. All right, so now what we need to do is if I just pin this, it's going to be displaced. I'm just going to see if I can mobilize that with maybe a towel clamp. And pull that down a little bit. And it will compress down a bit with the tension band. I've got solid bone there. One of the principles when you're doing a pin and tension band repair is that your pins are meant to be straight and parallel. If I'm hitting the caudal cortex there. Okay. And I'll leave that long. Thank you.
Yep.
So I'll put in my second pin here. So that's the caudal cortex there. Came through there. So the reason why we need to keep our pins pretty close to parallel is that we want to be able to compress that fracture with our tension band. I see that there's some questions there. So there's a question about whether I think that GPs can do orthopedic surgery or not, and that depends on the orthopedic surgery and it depends on the surgeon as well. I teach a lot of courses, and some courses, or some vets that are at the courses I teach, I'm just so impressed with and think that, you know, they're really capable of doing a lot of different types of surgeries, and then some people are less experienced and I feel less confident that they you know, that it's appropriate for them to be doing more advanced procedures. So, for example, a simple, you know, a tibial crest avulsion fracture like this, I think that if you're, you know, a good general practitioner surgeon, I don't see any reason why you wouldn't be able to do this. You know, femoral head and neck excisions, I think, are well within the range of a lot of GP vet surgeons. I think some fractures are within the range, again, depending on your experience. But like, for example, TPLOs, I know how I've struggled getting competent in doing TPLOs, and it took me about 100 to get really comfortable with doing them. And our residents scrub on, you know, 100 before they even think about doing one on their own. And that's doing one on their own under our supervision. So that's still very displaced there. I'm not very happy with the amount of reduction I've gotten there, so I'm going to have to come up with a different plan here. And a lot of surgeries are fine if everything's going well, but when you run into problems, do you have the knowledge and the equipment to manage that complication or that unexpected event in surgery? That is really quite displaced. I don't want to put new pins in because then I'll fragment the proximal segment. That's pulling down a bit. Yeah, that's much better. There's still a little gap there. I think that's fine. So now I'll redrive that pin, try to find that same hole. So I think like patella luxations, routine tibial crest transposition on a type grade 2 or 3 patella luxation, I think is well within the realm of a good general practitioner surgeon, whereas a grade 4 or a TAT patella luxation, I think that might be too small.
Yeah, yeah.
Grade 4 luxation or a cat luxation, I think is, I struggle with those. Can I get another pin cutter, please? Thank you. So there is an open physis because this dog is really young. And so we are recommending that these pins be removed in about 6 weeks, or all the implants be removed in about 6 weeks. So we're just getting a bigger pin cutter here. So my pins were a little bit divergent, and so that's why I couldn't tighten the cerclage wire. But by taking one of the pins out, it allowed it to slide down that. I think the other really important factor when deciding which surgeries are appropriate, I've touched that with my head. Hold on. Which surgeries are appropriate for a general practitioner to do. The other thing is just making sure that if the owners can afford referral, that's been offered. And if you offer referral and they refuse it and you do it, then you're covered if you have complications. Can I get some, we'll go ahead and get the suction. Can I please get some 2O PDS? I had this discussion. I taught a workshop last week for a couple of days, and we had this discussion about younger vets that want to do some more advanced procedures and how they can justify charging full price for them when other more experienced vets in the practice have done a lot more of them and they charge the same price. And I said one way around that would be to charge full price for the initial surgery, but if there are complications, that those complications are covered. or at least in large part covered. And that might allay the concerns by the owners of paying full price for a surgical procedure. Yep. So I'm just closing the periosteum up over the top of this. And trying to cover the tips of these pins, I think, is going to reduce the likelihood the pins are going to migrate and cause a seroma. So yeah, as long, I'm a big believer in informed consent, and so if you explain to a client that you're going to be doing the surgery, you haven't done a lot of them before, you're comfortable with doing orthopedic surgery, if you do the surgery, it's going to cost them $2,000, and if they go to a specialist, it's going to cost them $5,000, and just let the owner make that decision. You just don't want somebody coming back to you and saying, well, why did you do the surgery when there was a specialist close by and I would have opted for a referral? So you just have to be transparent about stuff. When I'm finished closing the deep connective tissue, I'll go and check the streamer to make sure there aren't any questions that I've missed. Just monosin, yeah. All right, so just an intradermal there. I think you might close in a couple of sub-Q sutures there. All right, so I'll go and check the streamer and make sure there aren't any questions that I haven't answered. Hi, Ohio. Hi, Toronto. You're welcome, Mike. Greetings from Egypt, veterinary student. Hi from Turkey. So Paul, I assume when you say any tips for someone about to start a surgical internship that you've already gotten the internship and that you're starting, or are you asking how to get a surgical internship? In answer to the second question, how to get a surgical internship, I think that most places like you to do a general internship first, although I don't think that that's absolutely required. And in order to get a surgical internship, I think that making good contact and trying to spend some time at the practice that you're hoping to get the internship at, I think is really helpful. And just volunteering there and hanging out. As far as if you're about to start a surgical internship, as my wife, who's an equine internal medicine specialist, always says to her prospective interns, recognize that you're going to have to work really hard for the year. And so just, work hard and don't complain about stuff and try to keep a sense of humor about things. I know that when I have, those are the qualities that I look for in a intern or a surgical intern or a resident, is somebody that's happy to work hard and, to have a laugh and, to have a good sense of humor. So Paul is about to start a surgical internship, so congratulations on that. That's very exciting. So yeah, just hard work and try to read it up on your cases ahead of time so that you can, number one, learn more while you're in there, and number two, impress your supervisors that you've taken the time to to study about them ahead of time. There's a question about previous video on medial tarsal collateral ligament repair. What's the fiber system called? They're called FastTac. And the drill hole, so the two drill holes, when you look at the tibiotarsal joint, you have short collateral ligament and a long collateral ligament on both sides. And the short is loose during extension and tight during flexion, and the dorsiflexion, and then the long is loose during dorsiflexion or extension, and tight when the hock is extended, like in the palmar direction. And so you just look at the anatomy and look where the insertion of the two collateral ligaments are, and that's where I drilled my holes. Hi North Carolina, hi UK. I will try to post the x-rays. I might do an x-ray review as a short story. Hi California, hi Brazil. Hello Mexico, hello Brisbane, and hello UK and Mexico again. Anyway, I'm going to go ahead and call it a day. So thanks a lot for watching. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. We'll talk to you again soon.